Good morning.
Morning.
Hello.
Yes, we hear you
Morning.
very clearly. Please. Yeah.
Amazing.
Would like to invite Professor Istvan Petak will present about the solution of AI in the for the decision of the targeted therapy and immunotherapy, depending on the profile of biology. Please.
Thank you so much. Thank you so much. It's a great pleasure to join you at this amazing conference, and thank you for your presentation. I really enjoyed also. Unfortunately, I don't understand Vietnamese, but I could see the slides and the sources. It was excellent, and congratulations to your presentation. And so it's my great pleasure to join you. And I hope that I will meet some of you next week during my visit in Vietnam. I'm looking forward to meeting you, and but it's a great opportunity to meet with you online this morning.
Yes, it is okay, Professor.
Fantastic. Without hesitation, I start my presentation. From the introduction, you may learn that I'm a physician scientist and share my screen. Actually, I graduated in 1995. I hope before any targeted therapy was approved. So one of the first ones, even rituximab or trastuzumab was in 96, 97. Fantastic. After my graduation, I'm just feel lucky introduction, you may enjoy this immense advancements. Actually, I graduated in 1995. The past 3 decades. Before we are all lucky to live through this time. So one of the first ones, rituximab or trastuzumab is really exciting because we started to use after my graduation about the biology of cancer. Lucky to enjoy this immense and advancements in oncology in the past 3 decades. Can you hear me? So I think we are all lucky to live through these times of these changes.
Thưa các bạn, thì
And
giáo sư
oncology
Istvan
now
Petak
is
đến
really
từ Đại học
exciting
Illinois tại
because
Chicago,
we
Hoa Kỳ, là
started
một
to
người đã có hơn
use
3 thập kỷ
what
trong
we know about the biology of
dành ra để
cancer
nghiên cứu về lĩnh
in
vực
our
ung thư
clinical
học chính
practice,
xác. Và hôm nay
and
thì
that's
thầy
so
xin phép được
amazing.
rất là hân hạnh sẽ được giới
And
thiệu về chủ đề là các giải pháp trí tuệ nhân tạo nâng cao trong việc làm hỗ trợ đưa ra quyết định cho các thuốc lâm sàng trong 2 lĩnh vực rất là mới. Thưa các bạn, thì Phó sư Phan Cẩm Phương Petak đến từ Đại học Illinois tại Chicago, Hoa Kỳ, là một người đã có hơn 3 thập kỷ trong đó là dành ra để nghiên cứu về điều trị miễn dịch trong ung thư học chính xác. Và hôm nay thì thầy xin phép được rất là hân hạnh sẽ được giới thiệu về chủ đề là các giải pháp trí tuệ nhân tạo nâng cao trong việc làm hỗ trợ đưa ra quyết định cho các thuốc lâm sàng trong 2 lĩnh vực rất là mới đã được
If you're ready, we can continue and we can jump into the presentation. So today, so I've been doing decades of research on different stages, on different stages of precision oncology. Now the next phase.
Yes.
So, what I'm excited about is to use computational continue and we can jump into artificial intelligence in presentation, helping us to find the right drug for our patients at the right decades of research and different just stages on different stages of precision oncology. Now the next, I was one of the member of the teams and what I'm excited about is to use molecular profiling technologies. So we really needed technological advances first in identify the genetic alterations, the right driver alterations for our patients at the right time. Spoke about and previous presentation. Just a little. We first have background to know what we think about, and it was one of the important members of the teams who next generation sequencing was discovered. Molecular profiling. So we really needed technological in a Nature paper first to and in 2008. the genetic alterations, driver alterations, sequencing was introduced by previous presentation. Because we first have to know what we think about, and that was the first. It was an important discovery. Immediately, several groups in the world started to develop actually describe the gene panels, because we realized that, and in 2008, it would be not feasible the first next-generation sequencing. These cancer genes introduced by 454. Simply the sample is not enough, and the time is not enough. So we have to do it in parallel. And technology. Immediately, several groups in the world started to develop. So we were doing this in parallel with the gene panels, because we realized laboratory it would be not feasible to and in 2010, these cancer genes had the privilege to be in an invited sample is not enough, and the time review paper, so we have to do it in drug discovery, where technology we forecasted the 2008, and so we were doing this in development of targeted therapies based on laboratory and later tumor. And we realized that in 2010, of course, what we know today, the privilege to be in an invited driver genetic alteration can review paper different type of cancer discovery, and not just one type of cancer, so it can occur in any normal tissue. So of analogy beautifully is that the same pathogenic based on the molecular profile of the tumor organs and different tissues. Realize the driver alteration can cause malignant transformation. The same driver genetic alteration can cause different type of cancers. Therefore, and not just one also type of cancer, so it can occur in any type normal tissue. So the analogy beautifully is that the same pathogenic agent can, if we want to use in different organs and different tissues, to the same driver alteration can cause genetic transformation. We must in multiple do a molecular profiling, and we must know. So therefore, the exact genetic. But we also learned that the same tumor type can be due to also related to multiple different types of genetic alteration. So if you want to use drugs according to meaning that present some mutations target genetic are very rare in individual cancer do a molecular profiling, and we must know occur the exact genetic cancer types and the background of the drug should be patient approved by FDA based on the presence of the genetic alteration instead coming of the tumor type. So this is which was first meaning that which occurred later in 2017 are very rare in individual cancer type agnostic therapies were approved occur in multiple cancer types, and it seems that drugs should be greater approved by FDA complexity problem that we anticipated instead of the past decade, because now we can identify the genetic cause of cancer in 95%, which occurred later in 2017. That's really exciting. This is the tumor type results of therapies were whole genome sequencing study published in Nature in 2020. It seems that we faced an international greater research group complexity problem that we anticipated. We know that in the past there is a limited number of cancer genes that identify the genetic cause of the cancers of cancer genes 95% from cosmic cancer database. That's really exciting. We can actually count the results of a census of cancer genome sequencing. It's a little bit over 700 in Nature in 2020. And the very exciting thing about this, if you think about this, that we have countable number of human genes. And now we need millions of years to develop a new gene. There is a limited number of cancer genes. The number of cancer genes must be also countable and limited in genes from cosmic to data biology of cancer. We can actually count. It's exciting to know the census of cancer genes, and we know more bit over 700. The new number of new cancer genes we discover thing about is less and less, because it's that we have countable number of human genes, and we need millions of years. But we also know that each gene can cover multiple different types of mutations. Cancer genes must be also countable and limited, and somatic mutations related to the biology of each cancer carries a combination. It's exciting to know that 4 or 5 mutations on average, minimum of them, and the maximum the new number of new cancer genes we discover is less and less because it's started to saturate. We only have but we also know that each gene can harbor multiple different types of mutations, actually cause potential 6 million is also mutations, but still, and on top of it, if we just think about this mathematically, we realize that the number of potential combinations of mutations in according to Bert-Falkenstein's difficulty research that because we only have to practice evidence-based alteration per pathway, we have to do clinical trials to prove potential the efficacy of drugs and also to compare different treatment options when we have just think about this mathematically, we realize that the time we need to do all the clinical trials with mutations in is calculated to be 14.4 million years. And even if we use real-world evidence-based medicine, instead of we have to do clinical trials to prove the efficacy of drugs and also to compare different so we treatment options when we have multiple different targets. At the beginning, we progressed the more time we need to do all the clinical trials is calculated to be 14.4 million years. These even if we use real-world data, instead of clinical trials, it will take us that they are actionable, and 200,000 is based on clinical trial data. So we need something now we realize that different because genes at the beginning we progressed with the more frequent mutations, cancer patients actually not rare, but the more frequent mutations. So, and even in these cases there are co-occurring other mutations. These we know that they are actionable, and because we have clinical evidence that they are actionable. Targets. But so based on today, only 5% of known cancer genes now we realize that actionable genes we define actionability in few percent of FDA cancer patients actually not rare, but the more we consider just so. And even in these cases, there are co-occurring other mutations that can only a fraction of patients actually have an actionable mutation. These in their NGS report. And so today, only 5% of known cancer genes are almost really all cancer patients have. If we define the genetic alterations in the reports that FDA the clinical interpretation or we consider the significance of level 1 alterations is not clear. But even only those who have an actionable mutation not necessarily respond to the target in their and many of them show resistance. And so these are the challenges we have almost all solve in the next years. Genetic alterations in the reports if you want to advance the clinical interpretation, very logical of the significance of that alteration is not clear. And even those who have an actionable mutation not necessarily respond to the targeted therapy, and many of them show resistance. So these are the challenges we have to solve in the next years with new technologies if you want to advance this concept, very logical concept of precision oncology.
Và trong 700 gen đấy thì sẽ có tồn tại khoảng 6 triệu tổ hợp đột biến khác nhau. Và thưa các bạn thì 4 đến 5 gen thì có thể thấy qua thì có thể tạo ra rồi thì sẽ có vai trò tạo nên một loại ung thư. Chúng ta có thể nói rằng là tại sao phải mất tới 14,4 triệu năm mới có thể cho đến nay toàn bộ các thử nghiệm lâm sàng để phát hiện ra khoảng hơn 700 điều trị có liên quan đến ung thư. Và trong những gen đấy thì sẽ có tổ hợp gen này 6 triệu tổ hợp đột biến. Đây là một cái thời gian có thể nói là không những là dài so với đời người mà thậm chí so với những cái một thời gian cứ 4 đến 5 gen thì cũng là rất là dài rồi, thì có thể tạo ra là nền văn minh có vai trò tạo nên vài chục nghìn năm thôi đúng không ạ? Thì trong số tới 14,4 triệu năm mới có thể thực hiện được toàn bộ các thử nghiệm lâm sàng để tìm ra thuốc điều trị thu được gần như là rất thấp. Xử lý bệnh nhân cho những chỉ có 5% tổ hợp gen này, dưới 5% số gen gây ung thư. Đây là một cái thời gian có thể nói là không hoạt hóa so với đời người mà thậm chí so với chưa đến 15% số những cái một thời gian của lịch sử nhân loại khi mà mình giải trình tự gen thế hệ mới tức là new generation sequencing NGS vài chục nghìn năm thôi đúng không ạ? Thấy các cái gen này có khả năng làm số 14,4 triệu năm này nếu như thử nghiệm lâm sàng một cách thủ công thì không đến 95% được báo cáo này là rất thấp khi mà chúng ta biết rằng chỉ có 5% biến đổi gen này dưới 5% không cho đem lại bằng chứng rõ rệt trên lâm sàng của người bệnh hoạt hóa. Chưa đến 15% số bệnh nhân
Perfect. Thank you so
khi mà mình
much.
giải trình tự gen thể mới, tức là New Generation Sequencing
Going
NGS,
so long without
mình thấy các cái
translation.
gen này có khả năng làm thay đổi
But
được hệ
I'm just happy that
mã di truyền.
Post here because I
Không đến
think this is a
95%
slide
các báo cáo này thấy là
it's very
các
important because
biến
it
đổi gen
addresses
này
the
không cho
problem
đem
we're
lại bằng
trying to
chứng rõ rệt
solve.
trên
So
lâm
thank
sàng của người
you.
bệnh.
And we already know the guidelines, sorry for how to interpret so long molecular profiles, how to rank genomic I'm just happy alterations that based on their importance post and here clinical because I think this is the actionability slide according to the it's very international important because it addresses professional the societies problem we're like trying to solve. ESMO, So thank you. And we all know this. And in these scales, and we already know the guidelines, how to interpret, measure the importance of each alterations, how to rank. But we have to keep in mind that these are based on guidelines, but clinical we don't have a unified international database professional societies like maybe ESMO is the most, and we all know this. And advancedly these scales curated us, but basically it's upon the molecular tumor measure the importance of each alteration. But we have to keep in mind that these are if a piece of evidence, but as we don't have which level a unified approved database of evidence alteration maybe guidelines. The guideline has a very clear logic that if there is a high level basically it's between the molecular tumor board, our patient, the biological and clinical characteristics, and the evidence used to generate of evidence between as a genetic alteration level and the efficacy of our drug evidence. Based on this guidelines of evidence, the guideline is more has a relevant, very clear logic, I would say. Of course, if there is a high-level matching between the trial was in patients with the same tumor type, biological and clinical characteristics, and the evidence trial used to generate the link between prospective clinical trial, randomized trial, and we have the highest efficacy and so our drug. Now, but this we have to keep in mind. Piece of this evidence is more relevant to, I would say. Of course, if that evidence is trial was in patients with the same tumor type, with the same genetic alteration, and that one therapy. The difficulty is that if we do a literature search to interpret our randomized trial, we find multiple evidence and so potentially dozens or hundreds. But these we have to keep in mind. Different these evidence level that link one alteration to one drug, and on top of it, each evidence is one by one can be linked to multiple alterations in the same tumor. One therapy. So in the difficulty is after introducing next generation sequencing to interpret our results, we find multiple dozen. Potentially dozens or hundreds started to form a molecular tumor board evidence level analyzed link more than 10,000 cases. And on top of it, in my research group, therapy can be linked to multiple alterations to guide clinical decision based on the molecular after introducing during this sequencing period in our work, we realized that we need a very high level computing to scale and standardize a molecular tumor board or decision making analyzed process. More than 10,000 cases. We started to develop in my research computational solution day by day advance try to guide our molecular tumor decision based on the molecular profiles. Maybe I stopped here during this period. We realized that we need a very high level computing to scale and standardize and improve our decision making process. So this is why we started to develop a computational solution to advance the work of our molecular tumor board. Maybe I stopped here for the interpretation. Yeah.
Thì với slide trước đây thì các bạn có thể thấy rằng các giáo sư đã giới thiệu về các cấp độ bằng chứng của các hội đồng khoa học khác nhau. Thì trong đấy ca bệnh đơn lẻ khác nhau, cứ mỗi một loại thuốc đòi hỏi sẽ bắt buộc là phải liên quan tới được một biến đổi gen duy nhất, phải có các hệ thống cái số lượng thử nghiệm để hỗ trợ xử lý được mà thực hiện nó sẽ là một con số rất là khổng lồ. Ở slide này các bạn có thể thấy rằng với cứ 20.000 thuật toán Đấy, đến 2020 thì con số này lên tới gần 25.000. Có thể hội đồng sẽ phải xử lý tới khoảng 10.000
You can continue, Professor.
ca bệnh đơn lẻ khác nhau.
Thank you so much.
Trong đấy thì
So
đòi hỏi sẽ
what
bắt
we
buộc là phải
developed is a computational
phải
model
có các hệ
of
thống
how a molecular
tin học
tumor board
để hỗ trợ xử lý
actually
được cái con số
reason
có thể lên
and
tới ví dụ như là trên
infer
này. Chúng ta
decisions
thấy đến năm
based on the
2019 là có tới
presence of multiple
20.000 thuật toán.
genetic alterations
Đến
in an NGS
2020 thì con số lại
report.
lên
So
tới gần
if we do
25.000.
a comprehensive molecular profiling,
continue, Professor.
we typically on average identify 5
Thank you so
mutations,
much.
and each
So what we
mutation
developed
can be linked to multiple
of
drug
how
targets
molecular tumor
and
board
multiple actually reason
treatment
and
options and
infer
each
decisions
connection
based on the presence
backed
of
by an
multiple
evidence,
genetic alterations in an
published
NGS
evidence, and each
report.
evidence
So
has
if
a
we
certain
do
weight
a
for
comprehensive
a
molecular
certain patient,
profiling,
and
we
one
typically
genetic
on average
alteration can be linked
identify
to
5
multiple
mutations,
treatment
and
options, and each
treatment
mutation
will
be linked to multiple
linked to
genetic
multiple
alterations in the same patient,
drug targets
and
and
it's
multiple
possible that one drug is
treatment
positively
options, and
associated
each with
connection,
with one alteration
but
backed by an
negatively
evidence.
associated with another
So what
published
we have to
evidence,
do
and
is
each
reason
evidence has a
based on
certain
the
weight
evidence scales
for a
based
certain
on
patient,
hundreds or potentially
and
1,000
one genetic
evidence per
alteration can be
case
linked to multiple
to do
treatment
the best
options, and each treatment option can be
following
linked to
the guidelines.
multiple
So
genetic
to
alterations,
really
the same patient,
standardize
and it's possible that
quality
one drug
control
is positively
scale
associated
and
with
this process,
but one
we need a
alteration but
computational
negatively
assistance,
associated
and
with
this
another.
computational
So what we have to do is
reasoning
reason
engine we
based on
developed
the evidence
is
scales
based on hundreds
or potentially
logical steps
1,000
implementing
evidence per
the
case
principles of precision
to do
oncology
the
clinical
best treatment
practice
option,
and
following
following
the
what
guidelines.
we
So,
know to
and following
really
the
standardize
guidelines
and
quality
in a
control
clinical
scale.
practice. And
So
this
it's
process
this
we
platform
need a
has been developed,
computational
validated,
assistance,
and
this
can be used
computational algorithmic
to
reasoning engine we
support the
developed
decision of the
is
oncologist and the
we
molecular
believe the
tumor
next
board.
logical
So
step
the input
implementing
is
the principles of
molecular
precision
profile
oncology
of the
clinical
patient with
practice,
NGS, and
following what we know,
histochemistry, and
the
following
output
the
is
guidelines
ranked
in a
clinical
report
practice that includes treatment options.
It's this platform has
ranked
been
by
developed,
a computational
validated,
score
and can
that
be used
actually reflects the aggregated evidence
support
level
the decision
of
of the oncologist
actually
and the
the
molecular
driver
tumor board.
alterations.
So the
target
input
is
and also
the molecular
the
profile
treatment
of the
options.
patient.
The
NGS
report is
tiered into
histochemistry,
three
and the
categories:
output is
high tier, intermediate, and low
ranked
tier
report
evidence level
that
includes
and also
treatment
in the
options
columns
ranked by
you
a
can
computational
it's
score
divided into
that
drugs
actually
approved in
reflects the aggregated evidence
tumor
level
type of the patient
or
actually
outside of
the
driver
other tumor
alterations
types or
the target
and
or
drugs in clinical
the
trials.
treatment options.
And
the report is
this is the
tiered
output,
into
and this is
three
discussed
categories: high tier,
with the
intermediate, and low
oncologist
tier
that
evidence level
standardize and
tier,
aggregate
and also in the
accelerates
columns
the decision-making process.
it's
So maybe I
divided
stop
into
here for
drugs
a minute
approved
for
in the
translation.
tumor type of the patient or
Thưa các
outside
bạn,
of the
thì
other tumor
để
types
giải
or
quyết được cái tình trạng là phải thực hiện
or
34.000
drugs
thuật
in clinical
toán trên
trials.
tổng số là 10.000 ca bệnh mỗi ngày. Theo
This
như
is
cơ
the
sở dữ liệu
output, and
của
this is
Đại học
discussed
Massachusetts khi được giới
with
thiệu
the
trên này
oncologist
thì giải pháp được đưa ra đó là các hệ
standardize and
thống
aggregate
được gọi là
accelerates the decision-making
GDA là
process.
các hệ thống
So maybe I stop
chỉ định
here
thuốc.
for a minute
Trong
for
đó thì
translation.
Genomics là một hệ thống GDA đã hiện đang được sử dụng. Thì
Thưa
dựa
các bạn,
trên
thì
việc và phân loại
để giải
các dữ
quyết
liệu
được
đầu
cái tình
vào
trạng là phải
liên
thực hiện
quan tới người bệnh
34.000
là
thuật
với độ biến
toán
di
trên
truyền,
tổng số là
thì
10.000 ca bệnh mỗi ngày.
Genomics sẽ có chức năng
Theo
là xử
như
lý
cơ sở
dữ
dữ liệu của
tìm
Đại học
kiếm
Massachusetts
các
khi được giới thiệu trên
điều
này
trị
thì
tương ứng với
giải
từng
pháp
loại
được
đột
đưa
biến
ra
này
đó
dựa
là
trên
các
cơ
hệ
sở dữ
thống
liệu đã được xuất bản,
được
các
gọi
bằng
là
chứng đã được xuất bản
được
các ấn
phẩm đã
GDA
được
là các
đưa
hệ
ra
thống
và
cũng như là
chỉ định
được
thuốc đưa
trong
vào
đó thì
sử dụng trên lâm
Genomics là một hệ
sàng.
thống GDA đã hiện đang được sử
Trong
dụng.
đó thì sử
Thì
dụng
ra dựa trên
thuật toán
việc và
riêng
phân loại
của các dữ liệu đầu
mềm
vào
GDA liên quan tới người bệnh
để
với độ
đem
biến
lại
di truyền đề
thì
xuất. Genomics sẽ
các
có chức
phương
năng
án
là
điều
xử
trị
lý dữ liệu với
tìm kiếm
và sẽ sắp xếp từ
các
trên xuống dưới theo mức
điều
độ
trị
tương
tương
thích
ứng
của các bằng
với
chứng
từng
đã
loại
được
đột
xuất bản
biến
và
này
theo
dựa
như
trên
đúng
cơ
là
sở
dữ liệu đã được
như
xuất
đúng
bản
các hệ thống bằng chứng mà mình đã sử dụng
ở các
các
ấn
trên
phẩm
đây
đã được đưa ra và cũng như là được đưa vào sử dụng trên lâm sàng.
Thank you.
Trong đó thì sử dụng thuật
So
toán riêng của các
we
phần mềm
first
GDA
have an output
để
from an
đem lại
NGS test
đề
that
xuất
lists their genetic
các phương án
alteration
điều trị
and current state of the art will list you these genetic alterations and drugs associated with these genetic alterations one by one in a list. What our solution does is combines what we know about all the alterations and creates a ranking of treatment options based on the genetic alteration and genetic current state of the art, because at the end of the day, these genetic alterations and drugs we choose for our patient based on the presence of all genetic alterations and biomarkers the patient had. And that's becoming challenging is combines when we know about all the alterations, genetic alterations, a ranking that are treatment options based on the totality of genetic alterations. Just one example, because at the end of the day, we have to make a decision the clinical problem we choose so we all patient that based on the presence of all evidence-based medicine biomarkers the drugs in patients who share that's becoming challenging or biomarkers. For example, in breast cancer, this is a concrete genetic alteration. This was first associated with different drugs. Triple negative breast cancer, just one example, treated according to the guidelines. What we know to demonstrate the clinical triple negative. So we all know that then, based on molecular evidence-based medicine, we test drugs in patients that the patient can share certain characteristics or biomarkers. For example, activating mutation in HER2 gene, ERB2. This was first in a few percent of breast cancer. Triple negative breast cancer is not treated according to the mutant. And it can be all the best therapy for triple negative with HER2 inhibitors based on molecular profiling. It was but of course this specific mutation carries multiple genetic alterations. Which, for example, an activating mutation in HER2 but then it also became also in a few percent of breast cancer. Although it's rare to have not HER2 mutation cancer, and it can be all breast cancer is also actionable with HER2 inhibitors. We know and in this case, we also know that, but of course, this specific mutation in the HER2 also drives some mutations, which but we don't have clinical evidence. It also became also obvious that the patient also was BRCA mutant. Although it's rare to have BRCA mutants for HER2 inhibitors approved for breast cancer in this case, but because we would need clinical trials that compare these. And in this case, we also know that actually share these genetic alterations. The problem is as we go on and on, but we don't have new therapies evidence against other genetic alterations in the same patient. The situation is becoming more and more complex. BRCA mutants or HER2 inhibitors. This is what I was mentioning, that in this case, we will need clinical trials that compare these treatment options in patients. Maybe I stop here for a minute. Actually share these genetic alterations. And the problem is as we go on and new therapies are coming against other genetic alterations in the same patient, the situation is becoming more and more complex. And this is what I was mentioning, that at the end of the day we will need 14.4 million years to solve this problem. Maybe I stop here for a minute for translation.
Mà cái genomics sẽ tìm ra các thuốc tương ứng. Trên đây là với ví dụ về dựa trên các bằng chứng đã được xuất bản về được sử dụng trong phần mềm trên từng biến đổi gen này. Đây là một bệnh từ đó thì mình có thể xác định được các loại thuốc tuổi với chẩn đoán ung thư, giống như một cái ranking từ trên xuống dưới. Cái hệ thống khi mà giải nhất cho bệnh nhân này phát hiện ra các gen đột biến, từ đó thì quyết định sẽ nằm ở các bác sĩ điều trị. Đây là một cái biểu đồ ven có thể hỗ trợ rất là tốt cho mô tả việc làm phức tạp. Đấy, mình phải dựa theo từng đột biến gen một mà rất nhiều bằng chứng khác nhau sẽ tìm ra các thuốc tương ứng. Dựa trên các bằng chứng đã
so just some examples. I'm sorry for these graphic pictures, but they are all actors, so we used to these just some case studies. And to end my presentation, we really enjoy situations when we can find the right targeted therapy for our patients. And this is just an example. We published a case report of a squamous cell carcinoma. Examples. I'm sorry for these graphic pictures, where all actors, so we can demonstrate this multi-step evolution also. Some case studies, and speaker was brilliant to end my presentation. That first the patient, of course, receives standard situations when we can find the right targeted therapy for our patients. And after initial example, we published case report, the first squamous cell carcinoma profiling of the head and neck performed, and where identified the amplification of the PI3 kinase evolution also. And now it's very interesting that talked about that first the drug that came out from radiolysable metformin therapy. It's a very interesting drug that after initial investigation now recurrence and oncology. The first purposes profiling approved, of course, we know this drug for that identified the amplification of the PI3 kinase gene, and beautifully now it's very interesting that very good response to simple drug that came out metformin, but analysis was metformin after a few months. It's a very interesting drug that is a progression. Investigation now we took a new biopsy that revealed purposes, new mutation, also a mutation in the this drug for MEK diabetes, MEK1, but MEK inhibitor to this therapy had a very good response. Combination of two simple drug targeted therapies, metformin actually resulted in complete remission. After a few months, that became extremely progression. So effective new biopsy for many years now. New mutation, also a mutation in the MEK. And the other case I wanted to present added MEK inhibitor at the end therapy is now dramatic situation of clinical situation. Targeted therapies, 50 years old, pancreatic neuroendocrine tumor patient was presented, became extremely multiple liver mets, so effective liver mets for many years, and kept the patient in complete remission. Laboratory results were very bad. The other case I wanted to present, so it's a very important decision, is a dramatic situation, choose the next line. Chemotherapy, 50 years sunitinib, pancreatic neuroendocrine patient. These are all approved and guideline liver mets, so options. So it's a typical situation when the oncologist faces a situation where you need to laboratory results for three therapies all approved by the guidelines. So it's a very important decision. This decision is critical. The patient has the next line. Liver function, so chemotherapy, sunitinib or everolimus. These are all side effects, and everolimus supporting therapy options. So it's a typical situation when the oncologist faces a situation of the doctor, you need to choose. So we organize therapies all approved by the guidelines, circulating and tumor. You choose any of them, but this decision is critical. The patient had a very bad liver function, so chemotherapy was very risky. Sunitinib using everolimus, side effects, and the patient had an excellent response and very quickly has a low efficacy of clinical experience of the doctor. It worked. This example, so we organized molecular profiling from circulating decision support derived DNA, ctDNA that reveals multiple genetic alterations. Here, I don't know. Drove our data. I don't want to run too much towards using everolimus. So maybe I just say one more slide because it's important and very quickly. So these were case reports, but of course, clinical symptoms. This just shows the clinical. This example is just application of a solution, but the importance evidence is coming from clinical trials in our clinical. So we published our maybe I stop here. I don't know Nature's Precision Oncology Journal. I don't want to run too much on the sheet. So maybe I just say one more slide because it's important. Precision oncology trial. So these were case reports, but of course, this just shows the clinical and the application of a solution. But the patients who received this coming from clinical trials, targeted therapies against molecular alterations in the tumor validation, who received Nature's Precision Oncology Journal, based on the Shiva score. A clinical trial that was the first randomized model precision oncology trial, fourfold higher response rate compared to those who had a low and computational score. So this patients who received in this trial, all patients received against molecular alterations in the tumor who received genetic alteration present in the tumor according to the state computational score, and we could differentiate calculated by a model efficacy of drugs within higher response population compared to those just shows that who had computation can move us forward. So this beyond was an important study because in this trial all patients received a matching therapy markers against what we can do manually, a genetic alteration present in the tumor according to the state-of-the-art guidelines. And we could differentiate between the efficacy of drugs within this population, and that just shows that computation can move us forward beyond the current state-of-the-art of treatment decisions based on individual markers, what we can do manually. Maybe we stop for a minute here.
Điều trị đái tháo đường, đúng không? Một thuốc rất là đơn giản, thế nhưng mà khi mà áp dụng genomics ở đây cho bệnh nhân đấy thì bệnh nhân đã khỏi hoàn toàn được cái tài liệu phát tay này liên quan tới thử nghiệm Shiva-01. Xong thì có thể nói rằng ở trên đây thì giáo sư có giới thiệu được 2 case lâm sàng, cho nên có một cái rất là đáng quan tâm liên quan tới việc là mình có thể dùng metformin có một thành tựu để điều trị cho bệnh nhân có thể ghi nhận được trong đây là một thuốc mà có lẽ là các bạn đều sẽ quen, tỷ lệ đây là điều trị đái tháo đường, đúng không? Tăng lên rất là đơn giản, thế nhưng mà khi mà 69% áp dụng so với những cái quyết định mà genomics áp dụng cho bệnh nhân đấy thì bệnh nhân đã khỏi hoàn toàn complete remission, giới thiệu xong sắp xếp thuốc từ 6 năm như mình đã nói ở cái của Genomics AI để nói về ở các slide ở trước đây. Khi mà ứng dụng được Genomics vào thì có một thành tựu mà có thể ghi nhận được trong thử nghiệm Shiva-01, đấy là cái tỷ lệ đáp ứng điều trị tích cực tăng lên.
Professor Turno, after the study, just beautifully said that this type of computational solution is really help us implement the concept of precision oncology. The concept is to choose the right drug for our patient individually. And that's the essence of precision oncology. But we need tools and methods. Professor Turno, after the study, decision-making beautifully validated. So we have to bring together computational solution is really precision oncology and evidence-based concept of precision. That's why the concept is to choose the right drug for our patient. This was individually supported by the essence of precision oncology. But we need tools and methods working that makes this decision-making standardized and validated. We also presented our results. So we have to bring together this concept of precision oncology and evidence-based medicine that describes, and that's why I think the results of real world is very important. This was also supported by prospectively written by the in an observational clinical trial, precision oncology in lung cancer patients, where we found patients who received also presented our targeted therapies, 15 different drugs this year with high score in June. Computed score actually had multiple times longer progression-free survival and overall patients. Actually, strikingly, many of these patients are alive in an observational clinical trials over 5 years. Lung cancer patients, where we found shows us that patients who receive the biology of cancer is extremely complex and complicated with high computed score. It actually had multiple times longer the progression-free survival. Combinations of mutations are determined by strikingly the biology of these patients are not all combinations are feasible for the cell over 5 years. Therefore, now this is just shows us that although the biology of cancer is extremely complex and complicated, simply because actually there are certain situations when cancer cell cannot the possible combinations of mutations are determined so by the right therapy or combination of the cell or the right sequence of therapies we can drive the cancer cells to stop or die. And this is so exciting because it shows cancer even cure with targeted therapies. Now we know that in the future more and more patients will be successfully treated and cured cancer cell if we cannot combine further what we know about the biology of cancer. So with the right therapy or combination of choose the right sequence of therapies, we can drive the cancer cells to stop or die. And this is so exciting because it shows that it's possible that in the future more and more patients will be successfully treated and cured if we combine what we know about the biology of cancer, we do molecular profiling, and we choose the right targeted therapy for our patients. And maybe I stop here for a minute.
Sẽ giúp cho rất nhiều bệnh nhân có thể càng ngày càng có nhiều bệnh nhân trong tương lai sẽ được hỗ trợ bằng
trên này là một
do
đầu tiên
chúng ta biết rằng ung thư là bệnh liên quan tới gen và tế bào. Vì với những cái hệ thống mà có thể xử lý thông tin rất là nhanh, có phát hiện được các đột biến và linh link với các thông tin về điều trị tương ứng một cách nhanh chóng, thì này các hệ thống chỉ định thuốc, hỗ trợ chỉ định thuốc sẽ giúp cho rất nhiều bệnh nhân có thể
lựa chọn phác đồ điều trị
càng
cho
ngày
bệnh
càng
nhân
có nhiều bệnh nhân
trở nên nhanh hơn và sẽ được hỗ trợ
bằng
hơn rất là nhiều. Như trên biểu
do
đồ trên này,
chúng ta biết rằng
có thể
thấy
thấy
bệnh
rằng
liên quan
là
tới gen và tế bào,
thời gian sống của các bệnh nhân cũng
với
tăng
những
lên.
cái hệ thống mà
Những
có thể
bệnh
xử
nhân
lý
khi
đã
đã
được
được rất là
điều trị
nhanh
bằng
và
genomics
phát
và
hiện được lựa chọn các phác đồ điều trị theo genomics
thông
thì
tin về điều trị tương ứng
thời gian sống của người ta
trung bình cũng tăng lên rất nhiều so với các bệnh nhân ở giai đoạn trước đây khi chưa có sự hỗ trợ ở các phần mềm này.
Việc chúng ta lựa chọn thuốc, lựa chọn phác đồ điều trị cho bệnh nhân sẽ trở
And
nên nhanh
we also
hơn và đạt hiệu
presented
quả cao hơn rất là nhiều. Như trên biểu
our
đồ
interesting
trên này
findings
thì
in
có thể thấy
related to
rằng là
checkpoint
thời gian sống của
inhibitors
các bệnh nhân
based
cũng tăng
on
lên. Những
multiple
bệnh nhân khi đã
clinical
được đề xuất điều trị
trial
bằng genomics
datasets
và
presented
được lựa
by
chọn các phác đồ
the
điều trị theo
Dana-Farber
genomics thì
Institute,
tỷ lệ
and
thời
we
gian
found
sống của người
that
ta trung bình cũng tăng lên rất nhiều
this
so với các bệnh nhân ở giai đoạn trước đây khi chưa có sự
precision
hỗ trợ ở các phần
support
mềm này.
also can identify patients who are more likely and we also presented for those who don't, interesting findings in related to checkpoint inhibitors, analyzing the molecular multiple clinical of trial datasets we already presented by the Dana-Farber Institute. And we found that can make the next this computational decision support NGS also can identify more advanced computational more likely assisted reporting from checkpoint inhibitors, moving from those who don't, mostly the annotation of so basically simply genetic alterations into more advanced clinical decision support we already where we can really match to wrap therapies not just to mutations, we can make the next step to the whole tumor, the current individual molecular profiling through a more advanced computational we don't only assign that moving therapies to individual mutations, it is possible individual in cases genetic alterations current standard reporting decision support don't where we can identify any therapies not just to mutations we can still find to the whole options by aggregating individual molecular profiles that and because multiple genetic alterations in the same patient to one therapy so to individual mutations it is possible we identify that treatment in cases in where almost 100% standard of our patients 85% don't if we consider only identify any actionable if we consider therapy we can still find compared to the 50% by aggregating treatment evidences from other methods so and multiple genetic alterations in the same patient to one therapy was so we can still identify we identify treatment options in treatment options based on the 100% of our patients 85% profile if we consider only label options and 100% if we consider off-label options soon compared to the 50% sure that treatment option rate from other methods so and in this patient where we originally no therapy was found we can still identify because it's really the end because it's the last treatment options based on the basically molecular profile especially very excited about advancements of artificial intelligence and computational technologies because I believe this helps us move towards the next phase. But I can, in medicine in general, especially precision oncology, one more slide, because it's generally the end that, because this is the last slide, decades of advancement basically evidence-based medicine, while I'm now especially very excited about evidence-based medicine, personalized medicine, artificial intelligence and computing technologies, computational tools. I believe this generation of medical devices the next phase in medicine in general, especially precision oncology and computational medicine in general that when we can combine this with decades the work of advancement of evidence-based medicine and to advance now we can combine evidence-based medicine with personalized medicine to our cancer patients using so with this computation. I really want to thank you for your kind attention and I'm looking forward to to meet many of you in the next decision support hopefully in the next years and work together to we can combine this with the work of a molecular tumor board and to advance and
Ở những
scale
slide
and
cuối cùng thì
improve
giáo sư đã tổng kết lại và so
care
sánh
to
về
our cancer
việc có
patients.
sự hỗ trợ
So with
của
this,
truyền thông miễn và
I
những
really
công
want to
nghệ
thank you for your kind
phân tích,
attention,
giới thiệu thuốc dựa trên
and
trí
I'm
tuệ nhân
looking
tạo
forward
so với việc là chúng ta chọn thuốc
to
thủ
meet
công
many
dựa
of
trên
you
các
in the
báo
next
cáo về giải
weeks
trình tự
and
gen thế hệ
hopefully in the
mới.
next year.